I was asked to speak about kind of where do we go once we've got that risk score, where do we go? And very much about intelligent identification. That's what the stratification tools give us, some intelligence to identify our patients. And then what do we do about intervention and intelligent intervention? I'll move on to that. We'll be talking about what we do as a company in a minute. So tried to put this in a bit of a picture. We've got this data, SUS data, primary care data, some of this other kind of specialist data coming into a warehouse. That goes through the risk stratification engine that you've just been looking at, and that comes out with a risk score that you can then look at some of those conditions. What we've been involved with Docobo is on our Artemis product, which is about the god of hunting, so about hunting people, that's where the name came from, is we take that risk score, then we take that data as well, and we start producing a range of dashboards to allow CCG teams, allow GPs, allow community teams to drill down to find specific patients and identify them. Statistically agnostic system, so we use a range of different models that can, risk stratification models that go underneath there. But it's a web-based long-term condition dashboard. Allows you to filter, and I'll show you some pictures, filter down to COPD or comorbidities, a range of disease groups to drill down and find your patients there. And very much as you look at CCGs and then compare various GP practices against each other, you can identify needs. And certainly we were commissioned by NHS Surrey to develop this model for the whole of Surrey, and it's running there. And certainly I've noticed the GPs are saying, oh, I didn't even know those patients were having all that activity going on. Because they get admitted into hospital, get discharged to community teams, and it carries on. He may get a few letters, but his receptionist puts that into the system, and it's only when he sees the patient that he sees all this activity. So it's highlighted utilisation that he wasn't even aware of. So that's what we're doing. Also allows you to look at predicted costs against actual costs, because you always map in every year. And you can look back in years and bring those two sets of numbers together and look at changes over a period of time, changes in risk score and the like. And what that does, it identifies need. And we've got that triangle gives us a whole load of different need out there. And we've talked before, previous presenters have talked about those with the most need and the different needs, and how do we identify need and those people who need focused care. But it allows us intelligent management of patients, so optimization of medicines, polypharmacy issues, are multiple medications causing other problems that we're not quite aware of because they've been prescribed from different locations. Condition-specific optimization, how can we optimize the care for COPD patient with heart failure or a range of comorbidities there? How do we assign interventions and be intelligent on that? And the beauty about these models, that regular refresh allows you to track changes. Has your intervention made a difference a year later? Can I see that changes I thought were going to happen by the intervention? Have they happened? Which means you can look at benefits realization. Has that person's predictive cost gone down? If you don't do randomized control trials, which you don't do in operational work, and that a lot of our work has been an operational rollout of telehealth, so therefore you don't have all the papers that are allowed to be published in the journals, but you see a lot of benefits. How do we track those? Risk stratification is actually a very excellent tool. It's probably the only tool you can get to actually look at changes and look at benefits out there in operational practice. So that's Artemis. Some of the pictures you get from that, these are web-based views that the clinical teams can look at. Will give you the model of number of people and what things like non-emergency tariffs and day case and emergency cases. And this is some information from Surrey, but the interesting thing, in the whole of Surrey we've got 1.2 million people, is that a very high risk score is only about 600 people, and then 4,000, 5,000 people at high risk and the like. And when we're looking at intelligent application of technology to services, if you look at the high-risk people, we've got about £6 million cost there, total cost. But low risk, 243 million. If we can adjust that by 1% or 2% by saying, actually, do all these people need to go for repetitive outpatient appointments? Do they need to go? Do they really need, or can we send a text message to them and get them, or get them to go on the web and answer some questions? Can we do that? Actually, we can make a big saving of that 243 million Yeah, and actually these patients, if we save 10% of that, we'd save 600,000. You know, it's balancing that out. Then against intervention costs, because average costs here, £300 for those people, £10,000 for high risk. You've got to have something very cheap to intervene there. It's got to be £10 a year. So therefore it has to be automated. You can't have a human involved in trying to do something about that. So interesting stuff coming out of this, and you can filter by, you can click on various disease groups and filter down and look at numbers of different disease groups. Business case scenarios, touched on that. Here we can say, actually, what do we want to try and reduce, looking at the evidence that says hopefully we'll make some reductions to this when we apply an intervention, and we're talking about telehealth particularly in here, and services that utilise telehealth. And we can put an intervention cost in at the top and then get an idea of savings to identify and inform our business cases. Won't be perfect, never will be accurate or exact, but it will give us the feeling, the flavour to go. And the beauty is we can then look back at, over the year, previous year, and say, did we save those things? Prevalence of diseases, and we can compare, the model allows you to compare between the various CCGs here. We've got PCT and some CCGs, and what's your prevalence of asthma and cancer and the like. So allows CCGs to self-improve their quality of care, to help each other build up their provision and their quality of care. You can then drill down to individual patients to identify those who are at certain risk scores and identify appropriate interventions for those people. And it allows you to look at the last few years and look at various activities and health utilisation that's going on. And you can see some of these patients are becoming more active and having more contact with the health services as they become more poorly. So it's a tool to allow you to make some intelligent interventions. And I was asked just to talk briefly, when we start applying some of this telehealth stuff, when you look at the need, when you've got someone's need, what you need to also do is think about their abilities and their social status, if you like. What's their ability? Because we have a patient with a risk score of 85, with very, say, poorly COPD, but one can never use a computer, never has. One is quite happy using a computer. Well, in that case, our intervention, our technology we put in is different. The need is exactly the same, but we can say, actually, for that patient, we can just send them emails and get them to go on a website and answer the questions. Yeah, and that's a lot cheaper than necessarily putting kit in for those patients who can't use computers, who need it. And so, very much, this is not my long-term condition triangle along the bottom, and I couldn't fit a triangle in, so it goes along the bottom. But it's more my needability triangle, my needability strip, if you like. So here, more case management, elderly, less IT literate, they need specialist devices, and there's technology out there you can see. But as you go to the mild long-term conditions, or even someone who's quite serious but quite happy to use a computer, we can just send emails out with a URL on, a web address on that they go to their own web page, and they enter their data. They can see their data. Hey, they can see their medications. We can set up self-management plans where they can set their own goals and the like. All that data encrypted comes to a database where clinical teams view it, which is quite standard in telehealth via some web application. And the beauty of telehealth, you can very much tune it in to individual patients. So individual questions fixed on the patient's needs and their comorbidities, and you can communicate backwards and forwards, particularly some of the high-end devices and the tablet apps. You can get video messages as well, backwards and forwards, with the clinical team. So you can still see your patient, you can still see how they feel and how they're reading. A range of technologies to allow you to route alerts, tell people. So out of hours you can send the alert to an out of hours team, or in hours you can send it to the community teams. A range of different reports there. And the other thing that's very much come out is communication between teams. And it's important we link this data to other teams. So what we're looking at is things that are Dastra, which is the out-of-hours system, where out-of-hours GPs can see the data. If someone's on telehealth, they can view that within the Dastra system. If you have got an EMIS system, or it would be an ISOF system, that you can view that patient when they turn up at A&E, you can see they've got telehealth, and you can look at data to inform what you're going to do with that patient. Yeah? And whether you need to admit them, or whether you need to it's an anxiety issue and you need to calm them down. There's a lot of information. It's about sharing information and getting the appropriate technology solution to meet the needability of the patient, very, very much stress that. So a whole different ways of reaching people, which is important. The other side about sharing information is between social alarm and telehealth, and usually two teams, different management systems, different organisations will probably never get together. Let's face the facts, but the community alarm team, very good at the panic alarms, respond to that very well, very fine-tuned system with its own quality standards. Telehealth and healthcare in a different domain, but very much involved in dealing with the same patient and their carers. Well, what the nurses need to know is that someone had a fall, or the nurses need to know that someone was wandering the night before and what was done about it. So that when she logs into her system, or she's on TPP, or she's on ISOF, when she logs into the system, or the telehealth system, she can see if someone's fallen the night before, or if they've had a problem, as part of the data she sees. So that if someone doesn't put data in, she doesn't have to panic. If she knows if she goes around there and there's no one in, there's a reason for it. So we're trying to do work about how do we link these things together and accept the teams work separately, but provide the information when they need it. And that's an important thing. As opposed to moving data, we need to just provide information at the point when people need it. So that's about me up. Thank you very much. Hopefully that gives you a little bit of a flavour of where this is going.